Welcome to our YouTube channel. We bring in the most important topics relevant to practitioners every week. This week, we are going to talk about dermatological manifestations of congenital intrauterine infections. First, we'll start with congenital rubella. Congenital rubella syndrome was initially identified in 1941 by Norman Craig. Maternal rubella infection during the first 16 weeks of pregnancy often causes congenital rubella syndrome. During 2004 to 2012, there were 79 cases of rubella and 6 cases of congenital rubella syndrome were reported. In 2015, WHO, the World Health Organization, declared America as region-free endemic transmission of rubella and congenital rubella syndrome. In spite of America is free of congenital rubella syndrome, Rubella virus continue to circulate in other parts of the world, namely Africa and Asia. Congenital rubella syndrome has a classic triad, namely congenital cataracts, deafness, and cardiac defects such as patent ductus arteriosus. It often associated with growth restriction, and in central nervous system, it can cause microcephaly, meningoencephalitis, and mental retardation. In addition, it can have pigmentary retinopathy, hepatosplenomegaly, jaundice, radiolucent bone lesions in metaphysis, and thrombocytopenia. In the skin, it can cause diffuse eruption composed of blue-red infiltrative papules and nodules, and purpuric macules, classically described as blueberry muffin lesions. The blueberry muffin lesions are usually present at birth or within the first 24 hours, and new lesions rarely appear after age 2 days. Blueberry muffin lesions are not specific with congenital rubella syndrome. The histologic evaluation shows those are extramedullary hematopoiesis. It is seen in patients with congenital toxoplasmosis, CMV infection, erythroblastosis fetalis, and congenital leukemia, and twin transfusion syndrome. Congenital rubella syndrome can have non-specific maculopapular eruption, reticular erythema of the face and extremities, hyperpigmentation, and recurrent urticaria. The lesions of blueberry muffin lesions you can see in this picture as similar to blueberry muffin, what you can have in the morning time. But as I said, it often presents at birth, but most of the lesions present in the first 48 hours. Usually it does not happen after 2 days. The differential diagnosis of newborn with blueberry muffin lesions are as follows. It indicates dermal extramedullary hematopoiesis. It's seen in congenital infections such as toxoplasmosis, rubella, cytomegalovirus, enterovirus, Parvovirus B19, erythroblastosis fetalis, inherited hemolytic diseases, twin transfusion, neoplastic disorders such as neuroblastoma, leukemia, histiocytosis, and alveolar rhabdomyosarcoma. The diagnosis is usually done by isolating rubella virus from respiratory secretions, urine, CSF, or tissue. Sometimes the rubella titers will help, especially IgM or IgG antibodies. Most often we do the PCR for rubella in nasopharyngeal swab, serum, and urine. The prenatal diagnosis of congenital rubella syndrome should be pursued with the history of maternal rubella, viral genome in amniotic fluid, fetal blood, or chorionic villus sampling. Prenatal ultrasound can find out pulmonary stenosis, microcephaly, cataract, microophthalmia, and hepatosplenomegaly. So how do you treat congenital rubella syndrome? There are no specific therapy for congenital rubella syndrome. Supportive therapy and recognition of potential disabilities very important. Regular ophthalmologic examinations need to be done, especially to evaluate for cataract, permanent neurologic and audiologic sequelae, can happen in patients with congenital rubella syndrome. That means they need to be evaluated by neurologist and audiologic testing. Long-term multidisciplinary care is very important, often involve ophthalmology, primary care physician, neurologist, and ENT. There is an increased incidence of diabetes, thyroid disorders, early menopause, and osteoporosis seen in these patients. So these patients needs to be periodically evaluated for those diseases. But one important thing is CRS, which is congenital rubella syndrome, can be effectively prevented by immunization as it happened in Americas. The next one is congenital varicella. Infants can have congenital varicella infection or congenital varicella syndrome if the mom acquired Varicella-Zoster infection during the first 20 weeks of gestation. The incidence of congenital varicella is 0.4 to 1%. The highest risk seems to happen when the mom acquired the infection between 13 to 20 weeks of gestation. It can have low birth weight. The newborn can have low birth weight, ophthalmologic defects such as microophthalmia, Horner syndrome, cataract, and chorioretinitis. Neurologic defects such as mental retardation, seizures, cortical atrophy, encephalomyelitis, and development delay. Limb hypoplasia and flexion contractures and malformed digits can also be seen in patients with congenital varicella syndrome. It's often associated with GI and GU defect. In skin manifestations are vesicles and or scarring, often depressed and pigmented in dermatomal distribution. Sometimes it can result in cutis aplasia, like absence of skin. So how do you treat? Those who are high risk needs to be treated for Varicella-Zoster virus during pregnancy. Therapeutic abortion is not necessarily indicated. The prenatal ultrasound should be done to look for any organ calcifications. Treatment of mothers with severe varicella should be done with either acyclovir or valociclovir. Next one is neonatal varicella. It occurs when a pregnant woman develops chickenpox during the last few weeks of pregnancy or the first few days of postpartum. It can present as severe disseminated varicella in neonate, or it can present with pneumonia, hepatitis, meningoencephalitis, severe coagulopathy, and mortality rate with the neonatal varicella is very high. It's around 30%. So when you have a history of varicella in a mother in the last few weeks of pregnancy or immediate postpartum, one should evaluate and treat aggressively. When you look at the kid, they can have the erythematous, papular, sometimes pustular eruption all throughout the body. As we mentioned earlier, the mortality rate is very high, 30%. How do you prevent? When you have a history, give Varicella-Zoster immunoglobulin. If you do not have it, give intravenous immunoglobulin. And the treatment is by acyclovir therapy. So when to give acyclovir therapy? When the mom have varicella within 5 days before the delivery or within 48 hours after delivery. All these infants needs to be admitted and treated with IV acyclovir therapy. The next one is neonatal herpes. Neonatal herpes simplex virus infection range from mild self-limited illness to one with devastating neurologic consequences or even death. The incidence is high, 9.6 to 13.3 cases per 100,000 live births. Traditionally, 70% of the neonatal HSV are caused by type 2 HSV, but recently that trend has changed. Now the predominant organism is HSV type 1. Most of the infections occur during birth, peripartum. 10% happens postnatally and 5% from in utero exposure. The congenital intrauterine HSV infection is rare, which is only 5%. It's presented as skin vesicles or scarring, chorioretinitis, microophthalmia, microcephaly, abnormal brain CT findings. Majority of infants with cutaneous involvement have lesions at birth or at least within 12 hours of life. The risk of newborn infection is high to the extent of 40 to 57% when the mom has genital infection at the time of delivery. If the mom has recurrent infection prior, the incidence rate or infection rate is 2 to 5%. But one should remember, most babies with neonatal HSV have asymptomatic mom. So how do they present? It presents in three distinct patterns. One, skin, eye, and mouth disease. Second, CNS disease. Third, disseminated disease. The SEM disease account for 45%. They present with 80 to 85% have skin lesions. It can progress to severe infection if you do not start early therapy. CNS disease account for 30%. They do have skin lesions in 60 to 70% of them. There is a clinical overlap can happen. SEM disease, CNS disease can progress into SEM disease. SEM disease can progress into CNS disease. Sometimes the newborns can present as neonatal bacterial sepsis. Turned out to be it is neonatal herpes. 25% incidence is disseminated, meaning it has involved multiple organs like liver, lungs, adrenals, GI tract, and of course skin, eye, and mouth. It may progress into respiratory collapse, liver failure, and DIC. Even disseminated will have 75 to 80% of them will have skin lesions. So in patients suspected of neonatal herpes, thoroughly needs to be evaluated for skin lesions. The most infants affected with neonatal HSV become sick during the first 4 weeks of life. The SEM, the skin, eye, and mouth disease, tend to present earlier. Oftentimes, they exhibit their signs and symptoms 9 to 11 days postnatal age. The CNS disease exhibit a little bit later, which is 16 to 17 days postnatal age. If the patient has just SEM, the prognosis is good. When they have diffuse or CNS disease, the prognosis is not that good. The clinical features are skin lesions, fever, respiratory distress, and CNS dysfunction. What does CNS dysfunction mean? It includes seizures, lethargy, poor feeding, irritability, and hypotonia. Skin eruption may vary from erythematous macules to individual or grouped vesicular or widespread generalized vesico-bullous eruption affecting the skin and buccal mucosa. The vesicles of neonatal HSV may become pustular after 24 to 48 hours and eventually become crusted or ulcerated. In skin, apart from the vesiculation and ulceration, it can cause purpuric, petechial, and zosteriform lesions, as well as large bullae and skin denudation, similar to those seen in epidermolysa bullosa. So whenever you suspect neonatal herpes, do the Zang or send the secretion for PCR. Skin lesions most often seen on the scalp and face because those are all the presenting part during parturition. The fetal scalp monitoring is a risk factor for HSV for the same reason. Eye involvement seen only in 5% of these infants. They can have conjunctivitis or pathognomonic keratitis, like the geographic distribution of keratitis. The disseminated form of neonatal HSV affects the liver, adrenal glands, lungs, and the CNS. It is associated with the highest mortality, up to 60%. In the absence of skin lesions or other pathognomonic features, these patients can present as possible sepsis, unexplained pneumonitis, unexplained nonspecific findings such as thrombocytopenia, coagulopathy, hepatitis, fever, unexplained CS or pleocytosis, especially when it is associated with predominant lymphocytic in nature. So all these patients needs to be evaluated for HSV. The recommended tests are as follows: swab specimens from mouth, nasopharynx, conjunctiva, anus for HSV culture or PCR assay. Specimens of skin vesicles for HSV culture and PCR, CSS sample for HSV PCR, whole blood sample for HSV PCR, and whole blood sample for measuring alanine transaminases. When it is associated with liver dysfunction, especially increased ALT, there is high likelihood of being either HSV or CMV. So how do you approach this one? This particular algorithm was published in 2024 July in Pediatrics. So any vesicle, grouped or punched skin lesions suspicious of HSV, administer acyclovir, of course pending lab results. If the HSV PCR is available, do it. If it is positive, do the spinal tap for HSV PCR, cell count, CSF culture, bacterial skin culture, and empiric acyclovir, topical or oral antibiotic. Most of these patients are very sick, eventually ended up having IV acyclovir and IV antibiotic and admit those patients, the inpatient. If the PCR is negative, obtain skin PCR, obtain viral culture, and do the spinal tap in HSV PCR culture and bacterial skin culture, start acyclovir and the antibiotic. Submit for observation in case if the HSV PCR is negative and you need to do the needful, and if it is positive, you follow through acyclovir. So what are the risk factors for mortality? When the patient presents with CNS and disseminated disease, the mortality is very high. When there is a decreased level of consciousness at the start of therapy, prematurity. In those with the disseminated disease, having pneumonitis and DAC increases the mortality as well. The morbidity was greatest in infants with encephalitis, disseminated infection, seizures, or infection with HSV2 in contrast to HSV1. These patients tend to have severe developmental delay with seizure disorder ongoing. How to prevent the neonatal HSV? Education is vitally important in the prevention of HSV during pregnancy. The women may be seronegative, but the partners are maybe HSV positive. So you need to educate the first lady as well as the partner. Another important point is 70% of the infants with the neonatal HSV born to mothers who are asymptomatic. So thorough evaluation for signs and symptoms of genital infection and also seropositivity or negativity. In presence of genital lesions, cesarean delivery is recommended because almost 50% of these newborns contract neonatal HSV during parturition. And also avoid fetal scalp electrodes, especially with maternal HSV history. How to treat neonatal HSV? Acyclovir. Typically, the dose we use for HSV is 15 to 30 milligram per kg per day for affected infants. But recently, there are higher dosage or more effective than 15 to 30 milligram per kg per day. So what is the highest dose? 60 milligram per kg per day. That means 20 milligram per kg per dose every 8 hours. When we do this, one should know the side effects. They are hypotension, seizures, and thrombocytopenia that occurs in 25% of these patients. In SCM disease, you need to give for 14 days. In CNS disease, IV acyclovir needs to be given for 21 days. And suppression therapy, oral acyclovir for 6 months needs to be given after acute therapy is being completed, especially in infants with CNS disease. Subsequent, after discharge, the patient needs to be evaluated for ophthalmologic examination, and prophylactic topical ophthalmic preparations such as iodoxyridine, vidarabine, and trifluorothymidine should be initiated right away. Treatment of seizures, respiratory distress, hemorrhage, and metabolic aberrations needs to be done along with acyclovir. The next is congenital syphilis. Congenital syphilis is caused by Treponema pallidum. Usually happens around 16th week of pregnancy. The risk of CSF, the congenital syphilis, increases with greater maternal spirochetemia and longer duration of maternal primary or secondary syphilis. The risk of fetal transmission in untreated early syphilis is 70 to 100%. It's highly transmissible to the neonates. Of those who die from congenital syphilis, more than 80% of them are stillbirths. Among affected live newborns, 50% of them are symptom-free. So they need to be evaluated thoroughly and treated appropriately. Perinatal association with congenital syphilis include it can cause premature delivery, it can cause low birth weight, and it can cause small size for the clinical manifestations of congenital syphilis divided into two. One, early congenital syphilis that is appearing before 2 years of age, late congenital syphilis occurring after 2 years of age. The skin lesions of early congenital syphilis are generally infectious, and because there is no primary stage, they resemble those of acquired secondary syphilis. The way it differs from second stage syphilis is that the fetal lesions are generally more widely distributed, more severe, and of longer duration. The late congenital syphilis, they are hypersensitivity reaction or scars and deformities are direct consequences of infection. So what are the signs and symptoms of early congenital syphilis? Can have constitutional symptoms like fever and wasting, and they can have snuffles, nasal discharge, typically seen in 2 to 6 weeks of life, associated with ulceration of nasal mucosa. Sometimes it may involve cartilage, resulting in saddle nose deformity. It can cause hemolytic anemia, thrombocytopenia, can cause lymphadenopathy. Particularly, the epitrochlear node enlargement is highly suggestive of congenital syphilis. Most of the patients present with hepatosplenomegaly, 50 to 75% of them, they can have icterus, especially direct hyperbilirubinemia with jaundice and ascites. In skin lesions, it can cause papillosquamous lesions like diffuse eruption, especially in palms, soles, red and fissured, bright pink red, fades to coppery brown, rare vesiculobullous lesion, and eventual widespread desquamation. They can present as condylomata later and mucous patches like present in 30 to 35% of the cases like weeping, fissuring at mucocutaneous junctions, extend out from lips in radiating fashion that leads into ray gates, deep scars in the perioral region. It can cause osteochondritis. It's seen in 15% of the patient, usually asymptomatic, or it can cause painful pseudo-paralysis of Barrett. Periostitis most pronounced 2 to 6 months of life, usually diffuse, a calcification and thickening of cortex. Seen, it leads into saber chins. It can cause dactylitis, affect small bones of hands and feet, and spinal tap will show increased protein, mononuclear pleocytosis, and positive CSF mediator. The late signs of congenital syphilis are clutching joints like knee effusions, eighth cranial nerve deafness, frontal bossing, gummas involving skin, subcutaneous tissue, bone inflammation and ulceration, hypomenarche sign, thickening of inner third of the clavicle, Hutchinson's teeth, peg-shaped upper central incisors, hydrocephalus, interstitial keratitis, mental retardation, mulberry molars, ocular changes such as retinitis, optic nerve atrophy, paroxysmal cold hemoglobinuria, ray gates, perioral fissuring, saber chins, saddle nose, and short maxilla. This is the soul of a patient with congenital syphilis. One can see erythema, scaling, and fissuring of plantar surfaces in early congenital syphilis. And it's another child with hepatosplenomegaly, another child with condylomata later, here a newborn with mucosal ulceration and snuffles. This picture shows Hutchinson's teeth, late manifestation of congenital syphilis. How do you approach these patients? Their conventional diagnostic approach and reverse sequence screening approach. In conventional diagnostic approach, in those patients, those mothers with positive RP or VDRL, then do the non-reactive, toponymal test, whether it is non-reactive or reactive. If it's non-reactive, and make sure it is not false negative, and if it is everything is fine, they can be no need to follow them. In the reactive maternal toponymal test, they evaluate mother's treatment history. In the reverse sequence screening test, initial positive toponymal test, then run RPR VDR on them. They can be reactive or non-reactive. In reactive and also non-reactive, evaluate mother's treatment. So eventually, it falls into evaluate mother's treatment history for syphilis. There are three groups. One, completely untreated. The second one is treated 4 weeks before delivery and no evidence or concern of maternal reinfection. The third group is adequately treated. In the mothers who are completely untreated, evaluate the child. If the child is normal and the RPR VDRL is less than fourfold of maternal titers, then they are categorized into possible congenital syphilis. If the infant is abnormal for the physical examination or RPR or VDRL is higher than fourfold maternal titers, then it's proven or highly probable congenital syphilis. The second category, where the mom was treated 4 weeks before delivery, there is no concern for the reinfection. In those patients, run the babies again RPR VDRL. If the RPR VDRL is greater than maternal RPR fourfold or greater than maternal RPR VDRL titer, they are proven or highly probable congenital syphilis, similar to the one with abnormal physical exam. If the infant RPR VDRL not fourfold or greater than maternal RPR VDRL, if the physical examination of the baby is abnormal, again, they grouped into proven or highly probable congenital syphilis. If the infant physical exam is normal and the infant RPR PDRL is not fourfold or not greater than maternal RPR VDRL, then it is congenital syphilis is less likely. In those patients who are well treated and the infant's examination is normal, they are also congenital syphilis unlikely. Other category is reactive maternal RPR. This is the reverse category. In the evaluate, again, examine the patients and run RPR VDRL in the newborn. If the RPR VDRL same or less than fourfold of the maternal RPR, they are possible congenital syphilis. If the exam is abnormal or the fourfold increase or more than the maternal RPR VDR in a newborn, they are proven or highly probable congenital syphilis. This categorization is very important. The treatment is based on those categorization, which we are going to. The newborns were proven or highly probable congenital syphilis. Abnormal physical examination or the non-troponymal serologic titers fourfold higher than the maternal titer, or positive result in dark field or PCR assay for lesions in the body. Do the spinal tap, cell count, and other tests as clinically indicated, either long bone radiography, chest radiography, liver function test, neuroimaging, ophthalmology examination, and brainstem evoked response. The treatment is penicillin G 50,000 units per kilogram IV every 12 hours in the first week, then every 8 hours if the child is more than 1 week, total of 10 days therapy. The alternative is penicillin G 50,000 per kilogram intramuscular or single daily dose for 10 days. The preferred is admit those patients, place an IV line, give IV treatment for the total of 10 days. In the possible congenital syphilis group, normal exam, the serologic titers is less than fourfold, and one of the following: mother was not treated, mother was treated with the regime other than recommended in the guideline, and the mother received recommended treatment less than 4 weeks before delivery. Those patients, again, CSF analysis need to be done, CBC count, and long bone radiography. The treatment is very similar to proven penicillin G, 50,000 units per kilogram IV every 12 hours for the infants less than 1 week, and every 8 hours for the infants more than 1 week, for the total of 10 days. That is the preferred. The alternative is penicillin G, 50,000 units intramuscular single daily dose for 10 days. The third alternative is benzathine penicillin, 50,000 unit intramuscular single dose, recommended by some experts, but only if the components of the evaluations obtained are normal and follow-up is certain. But most of the time, we tend to do the first one, the preferred method. When congenital syphilis is less likely group, meaning normal exam and the titers are less than fourfold, and mother was treated during pregnancy and treatment was appropriate for stage of infection. The treatment was administered more than 4 weeks before delivery, and mother has no evidence of reinfection or relapse. No testing is recommended, and the penicillin G, 15,000 units per kilogram IM single dose is preferred. Alternatively, infants, those mothers, non-treponemic titers decrease at least fourfold after appropriate therapy for early syphilis, or remain stable at low titer, meaning VDR less than 1.2, RPR less than 1.4, 1:4, may be followed up every 2 to 3 months without treatment until the non-treponemal test results become non-reactive. The non-treponemal antibody titers should decrease by 3 months of age and should be non-reactive by 6 months of age. Patients with increasing titers or with persistent stable titers 6 to 12 months after initial treatment should undergo re-evaluation, including CSF and treatment with 10-day course of parenteral penicillin G, even if they were treated previously. The other group is congenital syphilis unlikely. Normal exam, the titers less than fourfold, mother was treated adequately before pregnancy, and mother non-treponemal serologic titers remain low or stable. In these patients, no investigation needed. In the newborn, there is no treatment recommended, but infants, the reactive treponemal test should be followed up serologically till it becomes negative. The benzathine penicillin 50,000 units single dose can be considered if follow-up is uncertain and the infant has reactive test result, according to some. The next is cytomegalic inclusion disease. It is usually not evident at birth. Most of the time, they present asymptomatic. The 10% of CME infection evident at birth, they will have direct hyperbilirubinemia and petechiae as a result of thrombocytopenia, purpura, hepatosplenomegaly, microcephaly, intracerebral, typically periventricular calcification, and retinitis. Development delays can occur in affected infants in later infancy and early childhood. The mortality of congenital CMV infection is 3 to 10% in symptomatic disease and 1% of all infants with congenital CMV infection. Congenital CMV is the leading non-genetic cause of sensory neural hearing loss in children in the United States. 20% of all hearing loss at birth and 25% of all hearing loss at 4 years of age is attributable to congenital CMV infection. Approximately 50% of children with CMV associated sensory neural hearing loss continue to have further deterioration. The vertical transmission of cytomegalovirus happen in following 2 ways: in utero by transplacental passage of maternal blood-borne virus, or at birth but it passes through an infected maternal genital tract. The postnatal acquisition also occurs via human milk. It is the most common congenital viral infection in the United States. It has a significant racial and ethnic difference. There is a high prevalence of CMV in black newborns, 9.5 per thousand live births. The lowest in white, 2.7 per thousand live births. These are the pictures of congenital cytomegalovirus infections. This is a 3-week-old with hepatosplenomegaly and another child with blueberry muffin lesions, must be within a couple of days. And another one with lots of thrombocytopenic hemorrhagic lesions on the back. The child had undergone a spinal tap. They can also have perivascular infiltration of the retina in congenital cytomegalovirus infection. Typically, you see periventricular calcifications, especially when the child presents with seizures. If you do a CT scan, you tend to see periventricular calcification, as opposed to in toxoplasmosis, you will have a diffuse calcification. So how do you diagnose congenital CMV? By viral titers and PCR test. Neonates with symptomatic congenital cytomegalovirus needs to be treated with valganciclovir. It is given by mouth for 6 months. If the infant cannot absorb medications reliably from the GI tract, then one should use IV ganciclovir. The side effects: 1/3 of the patient with valganciclovir, which is given by mouth, and 2/3 of patients who received IV ganciclovir develop neutropenia. So ANC needs to be done weekly for 6 weeks, then at 8 weeks, then monthly for the duration of antiviral treatment. Liver function test needs to be monitored monthly. Antiviral therapy restricted to patients who have moderate to severe symptomatic congenital CMV. Finally, congenital toxoplasmosis. This slide shows transmission of congenital toxoplasmosis, how the newborn contract toxoplasmosis. It can come from contaminated vegetables or contaminated meat. Then the mom transmits tachyzoids to the fetus. Then the newborn, contract toxoplasmosis. Mothers are not screened routinely in the United States. Signs and symptoms of congenital toxoplasmosis found during routine physical examination in infants at birth. More specific testing in CSF, dilated eye examination, CNS imaging can reveal evidence of infection. These patients can present as visual or hearing impairment, learning disabilities, or severe developmental delay, and become apparent in large proportion of patients with congenital infected toxoplasmosis. The chorioretinitis is seen in 70% of infected infants. The classic triad is chorioretinitis, cerebral calcification, and hydrocephalus. The additional signs such as microcephaly, seizures, hearing loss, strabismus, petechial rash, jaundice, generalized lymphadenopathy, hepatomegaly, splenomegaly, pneumonia, and thrombocytopenia and anemia can be seen in patients with congenital toxoplasmosis. When you do the CSF test, one can see high protein level, hypoglycuria, that means decreased glucose level, and eosinophilia. CT scan will show high calcifications and hydrocephalus. This is a child with congenital toxoplasmosis with profound hepatosplenomegaly. And it can cause chorioretinitis and can cause hydrocephalus and calcifications in the brain. Classically, it is described as a diffuse calcification in congenital toxoplasmosis in contrast to CMV, periventricular calcification. How do you treat congenital toxoplasmosis? One should use pyrimethamine, sulfadiazine, and fulinic acid. The pyrimethamine dose is 1 mg per kg every 12 hours orally for 2 days. Then 1 mg per kg daily for 2 to 6 months. 6 months should be considered for symptomatic cases, followed by 1 milligram per kilogram per day on Monday, Wednesday, and Friday to complete total course of 12 months, plus sulfadiazine 15 per kilogram every 12 hours for 12 months, plus folinic acid 10 milligram per dose 3 times per week orally during and up to 1 week after completing pyrimethamine. The duration of the treatment is recommended for 1 year. The prednisone is used if the CSF protein level is more than 1 gram per deciliter or when there is a severe chorioretinitis. The dose recommended is prednisone 0.5 milligram per kilogram, maximum 20 milligram per dose, every 12 hours until the CSF protein level is less than 1 gram per deciliter or the resolution of severe chorioretinitis. And if the prednisone is used, it should be started 48 to 72 hours after starting antitoxoplasmotherapy. This concludes dermatologic manifestations in congenital intrauterine infection. Thanks for watching.